Okay, so development of the respiratory tract and diaphragm. So the objective of this lecture is to describe the development of the respiratory system and associated developmental abnormalities, and to describe the development of the diaphragm, including its congenital abnormalities. So in this lecture, we will learn about the development of the respiratory tract, developmental defects of the respiratory tract, development of the diaphragm, and developmental defects of the diaphragm. So why do we learn these things? So first we will look at a clinical scenario. The baby of a mother who had polyhydramnios during pregnancy presented with excess fluid in mouth and severe coughing and cyanosis following feeding. So when we are done with learning about the development of the respiratory tract, we'll be able to answer these questions. What is the most probable birth defect? What is the embryological origin? And what other abnormalities will you look for in the child? So to identify what's the defect in this type of child and to treat them accordingly, you have to learn embryology. So before straight away going to the respiratory system, we will revise a bit on the basic embryology. Okay, so then you will have a clearer understanding. So if you go back to the beginning, we will quickly revise. So everything starts with the zygote, right? So actually with the fertilized ovum, you have the spermate in the ovum and you have the fertilized egg first. Then you have the zygote with 2 cells, right? And this divides while traveling through the fallopian tube into about 12 to 16 cells. And this is called the morula. And as it enters the uterine cavity, it develops a 2 cell masses and a cavity. This is called the blastocyst. Then you have an inner cell mass and an outer cell mass. So then this further develops into a bilaminar disc. Okay. So in the outer layer, you develop 2 cell layers. You have the syncytial trophoblast, the cytotrophoblast, and in the inner cell mass, in the floor, you develop 2 cell layers. You have the epiblast, and then you have the fibroblast. So this cavity is called the amniotic cavity. And this cavity, which was there earlier, the blastocyst cavity, it becomes the yolk sac. So then, if you take a look at this upper surface of the epiblast layer, this layer, if you look at it from above, you will see it as a plate. It's called the embryonic plate, right? So you will see a plate like this. It is more smooth shaped. Yeah, so in this layer, you get a streak. This is called the primitive streak. So this embryonic plate has a cranial end. Cranial means head end, right? This side is where the head develops. And this is the caudal end or the tail end, where the lower part of the body develops. So in the primitive streak, in the caudal end, you get a node called the primitive node. And at the center of the primitive node, you get a pit. It's called the primitive pit. Okay. So then, if you go back to transfer section, you have the cell layers, the epiblast cell layer like this and the hypoblast cell layer like this. And from the primitive pit, you get the epiblast cells moving inwards. Okay? So these epiblast cells moving inwards start to replace the hypoblast cells. So it replaces the hypoblast cells and form a layer called the endoderm. And then more cells move inward and are stationed between these two layers, between the hypoblast layer and the epiblast layer. And this layer forms the mesoderm. And the cells remaining outside form the ectoderm. Okay. And if we look at a longitudinal section, so this is the cranial end. This is the ectoderm. And you have the endoderm like this. And between that, you have the mesoderm like this. And then you have the primitive strip with the primitive node and the primitive pit. And after the cells form the mesoderm, a few more cells enter, forming a cord towards the cranial end. So this cord is called the notochord. This forms the spinal cord in the future, spinal vertebrae in the future. Okay. So now, so after that, so the formation of these three layers, ectoderm and mesoderm and endoderm, from the two layers of epiblast and hypoblast, has a special name. It's called gastrulation, right? So after formation of these three layers, something special happens called flexion. So this flexion happens in two directions, craniocaudal direction and the lateral direction. So this starts to flex like this, cranial flexion, and from the caudal side, caudal flexion occurs, and from the two lateral sides, lateral flexion occurs. Okay. Okay, so at the end of the flexion, you get something like this. So if you look at a transverse section, you have the ectoderm meeting its other end like this. You have the neural tube formation, the notochord. So neural tube is formed from the ectoderm. You have the ectoderm layer like this. So from the top of the ectodermal layer, you have two processes occurring like this, and these form the neural tube. I won't go into much detail on that. You'll learn about those things later. So just to understand, that's how the neural tube is formed. So then you have the notochord. And the endoderm meeting its other end forms the gut tube. Like this. And then you have the mesoderm covering these layers. Like this. So this outer layer is called the somatic lateral plate mesoderm, and this internal layer is called the visceral lateral plate mesoderm. And around the neural tube, you have the paraxial mesoderm, and in between you have the intermediate mesoderm. So for learning about the respiratory tract, the somatic lateral plate mesoderm and visceral lateral plate mesoderm are important. And if we look at a longitudinal section, if you first draw the gut tube, you have the gut tube like this. You have a small canal which joins the yolk sac called the vitellointestinal duct, and you have the allantoic diverticulum. Then, if you draw the ectoderm, you have the ectoderm like this. You have the neural tube and the notochord, and in between you have the mesoderm. So this is the longitudinal section of an embryo. This gut tube is divided into three parts: the foregut, the midgut, and the hindgut. So from the foregut, at 4th week of intrauterine life, you have a small bud appearing in the ventral aspect. Ventral means towards the abdomen side, right? To the front of the body. So you have this lung bud. So before that, we'll just mention that this area is where the heart develops. It's called the protocardiac area. And below that, you have an area called the septum transversum. We will learn its importance later on in the lecture. So, yeah. So if we look at only the foregut section, you have the foregut like this, and from the foregut, you have the lung bud coming forward. So if you look at a section like this, lung bud appears like this. This is the esophagus, and this is the lung bud or the tracheobronchial diverticulum. This later gets separated from the esophagus except for its proximal connection at the larynx region. So it forms two tubes like this, and the lung starts to divide into its main bronchi, and it starts to divide in a dichotomous manner. Dichotomous means always dividing into two. So when this grows into the this coelomic cavity, it takes a layer of mesoderm with it. Okay? Splanchnic mesoderm it takes with it. So you have a splanchnic mesoderm layer moving into the coelomic cavity along with the lung bud. Okay. So development of the respiratory tract. It begins at the 4th week of intrauterine life, and an endodermal diverticulum from the ventral aspect of the primitive foregut will develop into the respiratory tract, and it grows along its splanchnic mesoderm into the coelomic cavity. So the coelomic cavity around the gut, the foregut region, is called the pericardio-peritoneal canals. Then pleuropericardial folds will separate the primitive pleural cavity from the pericardial cavity, and pleuroperitoneal folds will separate the primitive pleural cavity from the peritoneal cavity. Okay, so about the pleuropericardial folds, I couldn't tell you, right? Okay, so if we look at a transverse section, we have the neural tube. We'll take just the gut tube like this, and you have the lungs developing like this. And on the anterior aspect, you have the heart developing. And between these two, you have two layers forming called the pleuropericardial folds. These folds separate the pleural cavity from the pericardial cavity, and these later form into the fibrous pericardium. Right? About the pleuroperitoneal membranes, we will see when we see the development of the diaphragm. So the tracheobronchial diverticulum loses its connection with the foregut except for its proximal attachment. So the proximal parts become the larynx and the trachea. This lung part divides into two, the left and right main bronchi. Then again the left divides into two and the right divides into three, the lobar bronchi. And each of these divisions are covered by splanchnic mesoderm. So after the formation of this lobar bronchi, they will further divide into in a dichotomous manner. Right? So this will result in 10 tertiary bronchi in the right and 8 in the left. And by the 6th month of intrauterine life, about 17 subdivisions will be formed. And after birth, that is postnatally, another 6 subdivisions will be formed. The terminal parts of the lung buds, the diverticulum, will form alveoli. Okay. So you know alveoli are where the air exchange happens. So the alveolar sacs increase in size and number during the last 2 months of prenatal life, and even after birth, up to 10 years, this can happen. So if you look at alveoli, you have two types of cells. You have simple squamous cells like this. These are called type 1 pneumocytes, right? And these tall cells are called type 2 pneumocytes. This type 1 pneumocytes is where air exchange happens. And these type 2 pneumocytes produce a substance called surfactant. This will help reduce the surface tension of between the air and the lung, the alveolar surface. This will prevent the collapse of alveoli when air enters the alveoli, right? So the development of these type 2 pneumocytes occur at 6th month of intrauterine life. So the type 1 pneumocytes, the squamous cells, and the type 2 pneumocytes, the surfactant cells, develop from the endoderm. And the cartilage, smooth muscle, connective tissue, and alveolar macrophages surrounding the lungs, the bronchial tree, develop from the splanchnic mesoderm. The visceral pleura, the pleura layer, which is in close contact with the lungs, is formed by the splanchnic mesoderm. And the parietal pleura is formed. The layer of pleura, which is in contact with the body wall, is formed by the somatic mesoderm, and the coelomic cavity will become the pleural cavity. Okay. So you understand, right? So you have the lungs like this, dividing with alveoli at the end. If you take a lung like this, you have the visceral pleura, and at the body wall, you have the parietal pleura. So this parietal pleura develops from the somatic mesoderm, visceral pleura develops from the splanchnic mesoderm, and between you have the coelomic cavity developing into the pleural cavity, and the surrounding cartilage, muscles, and the connective tissue developed from the same visceral or the splanchnic mesoderm, and the internal lining you have developing from the endoderm. So then we will look at developmental defects of the respiratory system. Agenesis of lung. So this is simply non-development of the tracheobronchial diverticulum, and this is very rare. So you will have absence of one lung or a part of the lung, right? So in this X-ray, so the black color, in black color you see air, right? So with the tracheobronchial tree with white lines, this is the normal appearance of a lung, and on the left side you don't see any markings. So this child has been born without a left lung. In tracheoesophageal fistula. So tracheoesophageal fistula develops when the lung bud fails to separate from the esophagus, right? So usually they should separate like this. If they don't separate, they will have a connection like this. And usually tracheoesophageal fistula, there are a few types, and it can coexist with esophageal atresia. Atresia means a failure to develop, right? So in esophageal atresia, you have the esophagus stopping like this, and the distal part can connect with the trachea like this. So this is the most common type of tracheobronchial fistula, right? So yeah, I had a diagram here. Here, this is the most common type. You have the esophagus ending without an opening and the distal part joining the trachea like this. So 90% of tracheoesophageal fistula are like this. And then in this type, there is only esophageal atresia and there are no fistula. So fistula means connection between two epithelial surfaces. Okay. So in this third type, you have a communication of the esophagus with the trachea. Both proximal and distal parts communicate with the trachea. And in this type, you have the proximal part connecting with the trachea. And in this, you have the proximal and distal parts connecting separately. So in these patients, usually they have other anomalies. They are called, the associated anomalies are called VATRL. So you have associated vertebral anomalies, anal atresia, cardiac defects, tracheoesophageal fistula, esophageal atresia, renal anomalies, and limb defects. So if you find a child with a tracheoesophageal fistula, you have to look for these other abnormalities. So then we come to another important defect, the respiratory distress syndrome or the hyaline membrane disease. So in this, so I already told you that type 2 pneumocytes which produce surfactant develop at the end of the 6th month of intrauterine life. So especially in premature infants who are born around 6 months, they will have insufficient surfactant. So there will be increased tension between the air blood surface and alveoli will tend to collapse. And also because of lack of this surfactant, there will be accumulation of fluid with high proteins with hyaline membrane bodies. So that's why it's called a hyaline membrane disease. This is a common cause of death in premature infants and is the result of newborn deaths in about 20% of the cases. For this, for premature babies, you can treat with glucocorticoids, and now artificial surfactant are available to give for these children. The fourth type of abnormality is ectopic lung nodes. So ectopic lung nodes is the formation of additional divisions of the lung bud. These can arise from the trachea or the esophagus. These are also very rare conditions, right? Okay, so we will go back to the clinical scenario. So initially, the baby of a mother who had polyhydramnios during pregnancy presented with excess fluid in mouth and severe coughing and cyanosis following feeding. Can somebody tell me what is the most probable birth defect of this child? So now we will look at another clinical scenario. So soon after birth, a baby developed respiratory distress. On examination, heart sounds were heard on the right side of the chest and bowel sounds could be heard over the left side of the chest. And on X-ray, bowel loops within the thoracic cavity could be seen. What is the most probable birth defect and what is the embryological origin? So when we learn about the development of the diaphragm, we will be able to answer this question. So if we go back to the flexed embryo, we will first draw the gut tube. So you have the gut tube with this, the vitelline diverticulum, the lentoid diverticulum. You have the ectodermal layer, the neural tube, the notochord, and here you have the protocardiac area and the septum transversum. So at this stage, it is at the cervical level, right? Cervical spinal level. Yes. So here you have the septum transversum. And if you look at a transverse section, you have the neural tube, notochord, the gut tube, the mesodermal layers. And if you look at this section, you will see the septum transversum like this. So the diaphragm develops from three origins. Four, right? You have the septum transversum, you have the pleuroperitoneal membranes, you have the esophageal mesentery, And then you have the lateral body wall muscles. So you saw the septum transverse in the initial stages. So if you look at for the developed embryo, you will have the vertebral canal like this and the aorta like this after the development of the vascular system. Here, this is the gut tube or the esophagus, and you have the inferior vena cava like this. And you have the visceral mesoderm layer or the splanchnic mesoderm layer like this, the intermediate layer, the paraxial layer, and the somatic layer. So the gut tube is connected to the posterior body wall by 2 layers of mesoderm like this. And this at the esophageal area, this is the esophageal mesentery. So here you have the esophageal mesentery, and at the anterior side you saw the septum transversum. So initially the thorax and the abdominal cavity are continuous. These are called the pericardio-peritoneal canals, right? So the coelomic, this is the coelomic cavity, right? So this space is called the coelomic cavity, and around the foregut it has a special name, the pericardio-peritoneal canals, right? So these are the pericardio-peritoneal canals, and from the lateral wall, developing inwards, you have a membrane, 2 membranes on either side, which are called pleuroperitoneal membranes. So these move inwards from the lateral body wall, right? So these gradually move inwards and finally gets fused with the septum transversum. So the septum transversum moves like this. And the pleuroperitoneal membranes gets fused with this, right? So after that, so we have 3 of our components forming the diaphragm. And later on, from the lateral body wall, we have moving inwards a layer of lateral body wall muscles. So from the lateral body wall, you have the lateral body wall muscles moving inward. So these are our four origins of the diaphragm, right? So this septum transversum makes up the central tendon. The pleuroperitoneal membranes and the lateral body wall muscles make up the musculotendinous domes on either side, and the esophageal mesentery forms the pleura. So the diaphragm is a musculotendinous structure which separates the thorax from the abdomen. Right? It consists of muscles originating from the lumbar vertebrae, sternum and lateral body wall. It converges to a central tendon and develop around the existing inferior vena cava, esophagus and the descending aorta. As you saw earlier, they develop around these structures And from the lateral body wall muscles, you have muscles originating from the lumbar vertebrae, sternum, and the lateral body wall. So these develop from the 4 embryonic components. Septum transversum develops into the central tendon. Left and right pleuroperitoneal membranes form the left and right domes of the diaphragm. And this is also formed by the left and right lateral body wall muscles. And the dorsal mesentery of the esophagus forms the left and right crura. So the anatomy of the diaphragm, I think you are thorough with now, right? You have done seen the dissection videos, and you have had the lecture, right? So the nerve supply of the diaphragm. So this you saw that the septum transversum initially develops in the cervical area, right? So if you don't go into much detail, you have the septum transversum here. So it develops in the cervical area first, right? Specifically C3, C4, and C5. And it receives nerve supply when it's there from these 3 cervical spinal nerves. This is called the phrenic nerve. And with development and with the lungs developing, lungs expansion, this moves downwards, right? The septum transversum moves downwards. So during flexion, the dorsal side of the embryo grows much faster than the ventral side. So this results in the septum transversum moving downwards, and it finally rests in the thoracic region, the lower thoracic region, right? So it drags this phrenic nerve along with it. So this results in the diaphragm having its nerve supply from C3, C4, C5 levels, and also from the lateral body wall muscles, from the lower 6 intercostal. So from the lateral body walls, the lower 6 intercostal muscles, you have origins for the diaphragm. So because of that, you get another supply for the diaphragm, a sensory supply from the lower 6 in thoracic nerves, intercostal nerves, right? The thoracic or the intercostal nerves. Yeah, so the septum transversum lies opposite the 3rd, 4th, and 5th cervical segments. The phrenic nerve from these segments grow into the septum. This happens through the pleuropericardial folds. You remember, initially we said that folds separate the pericardial cavity from the peritoneal cavity. So through these folds, the phrenic nerve enters the septum. And due to rapid growth of the dorsal part of the embryo compared to the ventral part, and due to the expansion of lungs, the developing diaphragm moves to the thoracic level and drags the phrenic nerve along with it. Okay, so these are self-explanatory, and as the peripheral part of the diaphragm is derived from the lateral body wall muscles, the lower intercostal nerves contribute to the sensory supply. Now we will look at the developmental defects of the diaphragm. So the main developmental defect you have to know about is congenital diaphragmatic hernia. This usually occurs because of failure to close the pericardio-peritoneal canals by the pleuroperitoneal membranes. So in this case, the pleural and the peritoneal cavities are continuous with each other, and the abdominal viscera will enter the pleural cavity. And this commonly occurs on the left side, right? About in 85 to 90%, this occurs on the left side. So if you look at the clinical features, you can see the abdomen. So what happens is abdominal viscera enters the pleural cavity. Okay? Enters the pleural cavity. So the bowel sounds can be heard in the thoracic cavity. So this X-ray shows the shows a child with left-sided congenital diaphragmatic hernia. So these are bowel loops, right? So bowel loops can be seen in the thoracic cavity. And when you keep a stethoscope on the chest, you can hear bowel sounds, right? So if you insert an NG tube, this NG tube can be seen in the thoracic cavity. So this is how usually these patients are diagnosed, right? By inserting an NG tube and taking an X-ray. And so as the bowel enters the thoracic cavity, the contents of the thoracic cavity are pushed to the other side. So the heart is pushed to the right side, and therefore you can hear heart sounds on the right side of the thorax. Okay? So during development, the lungs don't have enough space to develop, right? So there's lung hypoplasia. So hypo means reduced, plasia is development. So there's reduced development of the lungs. So there's respiratory distress and cyanosis because the child doesn't get enough oxygen. Usually these patients get worse, so the cause of death is due to the respiratory distress. Right, so if we go back to our clinical scenario, soon after birth, the baby develops respiratory distress, and on examination, heart sounds are heard on the right side of the chest, and bowel sounds could be heard over the left side of the chest, and X-ray showed bowel loops within the thoracic cavity. So what does this patient have? Okay, so these are my references. Professor Malkanthi Chandrasekara's Human Embryology book and Langman's Medical Embryology. So I think it will be good if all of you get the Human Embryology by Professor Malkanthi Chandrasekara and read it well. So it will give you the basic knowledge, right? It gives a really good explanation into this embryology and it's easy to understand. Right, after reading that, if you want, you can read the Langman's Medical Embryology, but it's a bit too complicated for you, I think, but it has good pictures and you can read around that as well. Right? Okay, so I think we finished earlier, right? So, thank you.